Hello friends, I am Dr. Nikita Pava. I am an obstetrician and gynecologist. So friends, let's learn today one of the interesting topics in obstetrics, that is application of Doppler ultrasound in obstetrics. Now what are the uses of Doppler ultrasonography? It is used to assess maternal, fetal and placental circulation in diagnosing and monitoring of pathological conditions during pregnancy such as fetal growth restriction, fetal anemia, hemodynamic complications in monochorionic twins. It is also used for the screening of pre-eclampsia and fetal aneuploidy. Now friends, let me tell you which vessels are measured commonly. That is umbilical artery, middle cerebral artery, uterine artery and ductus venosus. Now, what are the waveforms which are commonly analyzed to describe the diseases? So, as you can see, this is the cardiac cycle, this is the systolic peak, this is the end diastolic flow, this is the mean velocity. The most common Doppler indices which are measured are RI, that is resistive index, PI, that is pulsatility index, and S by D ratio, that is systolic by diastolic. Both RI and PI are the indirect measures of the resistance to the flow in the placental vasculature. In addition to these indices, the flow waveform may be described or categorized by the presence or absence of a particular feature. For example, the absence of an end diastolic flow, as you can see in this photograph, and the presence of a post-systolic notch. Now friends, let's start studying. Let me tell you some of the physiological changes in spiral arteries. As you can see in this photograph, spiral arteries are invaded by the cytotrophoblast cells and are converted into the uteroplacental circulation. Now, these uteroplacental arteries, they have a dilated and a tortuous lumen, a complete absence of muscular and elastic tissue, no continuous endothelial lining, mural thrombi and fibrinite deposition. Now, this conversion of the spiral arteries to the uteroplacental arteries is termed as physiological change. It has been reported to occur in two stages. The first wave of trophoblastic invasion converts the decidual segments of the spiral arteries in the first trimester, that is from 8 to 12 weeks. And the second wave converts the myometrial segments in the second trimester, that is from 14th week. See, this is first trimester change and this is second trimester change. First trimester only the decidua is invaded, and in the second trimester, as you can see, the myometrium also gets invaded. Now what does this do? It reduces the impedance to flow and it optimizes the feto-maternal exchange in the intervillous space. The diameter of the spiral arteries increases from 15 to 20 mm to 300 to 500 mm. Now, these changes as seen on ultrasonography. So friends, as you can see in this photograph, the normal pregnancy, the normal uterine flow in the first trimester is less of the diastolic flow. As the trimester increases, there is the increase in the diastolic flow in the second trimester and further increase in the diastolic flow in the late second and third trimester. So in a normal pregnancy, a uterine artery is characterized by low resistance and a high flow pattern. As the pregnancy proceeds, the diastolic flow increases and the PI, that is the resistance to the flow, decreases. Now, second is the umbilical artery. Similarly, in the umbilical artery development in the normal pregnancy, you can see that the diastolic flow is consequently increasing in the early second trimester, then further increasing in the late second and third trimester, and PI, that is resistance, subsequently decreases. Now, third is the middle cerebral artery flow. The middle cerebral artery flow is normally a high resistance circulation. See, as you can see in this picture, we change from first to second and third trimester. There is very little increase in the diastolic flow as it is a very high resistance circulation. Fourth is the ductus venosus Doppler. Now, what is ductus venosus? Ductus venosus is a venous shunt that directs oxygen-rich blood from the umbilical vein to the heart. It has three waveforms. The peak is the systole, the first peak which indicates systole. The second is the early diastole, and then there is a nadir of the waveform which occurs during atrial contraction. And third is the A wave, that is atrial contraction. Now let us study clinical application of these Doppler in obstetrics. First is the hypertensive disorders in pregnancy. Now friends, what happens in hypertensive disorders? There is defective placentation which leads to hypoperfusion, hypoxic reperfusion injury and oxidative stress. Because of that, there is incomplete trophoblast invasion which results in an abnormal uterine artery Doppler pattern. What happens? There is increased pulsatility or increased RI, matlab there is increased resistance to the flow in the uterine artery, and you can see an early diastolic notch. See friends, as you can see in this picture that this is a normal impedance to flow in the uterine arteries. In the second picture, you can see that there is increased impedance to flow and the diastolic flow has decreased. And in the third, there is very high resistance to flow in the uterine arteries with almost reversal of the diastolic flow. Now, second is prediction of pre-eclampsia. Friends, you need to remember that the most potent Doppler index for prediction is the increased pulsatility index, that is more than 95th percentile, and second, notching in the second trimester. As you can see in this picture that this is a systolic flow and this is a diastolic flow and there is a notch at the end of the systole. In a normal pregnancy, an early diastolic notch will disappear after 24 weeks of pregnancy. And important thing is the persistence of notch beyond 24 weeks is an evidence of inadequate trophoblastic invasion. Now, very important thing again, increased impedance to flow in the uterine arteries in pregnancies who are attending the routine antenatal care. It identifies almost about 50% of those that will subsequently develop pre-eclampsia. And increased impedance also detects about 30% of those that will subsequently develop intrauterine growth restriction. So friends, you can see how much important it is to measure impedance in uterine arteries. The clinical application of that is, according to the ASPRE trial, the risk assessment for pre-eclampsia in women should be done by combining maternal factors, mean arterial pressure, uterine artery pulsatility index and the mean maternal PAP-A levels and placenta-induced growth factor, that is PIGF, between 11 and 13 weeks. And very important thing, those women who are found to be high risk should be started with low dose aspirin, that is 150 milligram per day, importantly before 16 weeks of gestation. Now, second application of Doppler is in fetal growth restriction in umbilical artery. Friends, as you can see in this photograph, as the disruption of the villus vasculature increases, there are changes in the diastolic flow in the umbilical artery. When there is just 30% of the villus vasculature ceases to function, there is a decrease in the diastolic flow. Subsequently, when there is 60% of the vasculature gets obliterated, there is absence of the end diastolic flow. And further, when there is 70% or more of the villus damage, then you can see the reversal of the end diastolic flow in the umbilical arteries. Now, third is the MCA Doppler. How is MCA Doppler affected in FGR? Now friends, as we discussed earlier, that the fetal brain normally has a high resistance circulation. But as with progressive hypoxia, the diastolic blood flow increases. Why? To compensate for the decrease in the available oxygen, which we commonly see as brain sparring effect. Now this effect is seen as a result in which the cerebral PI or the MCA PI increases. Now this MCA Doppler is used in addition to the umbilical artery Doppler because changes in MCA are always seen after changes in the umbilical artery Doppler. Now most important thing which is measured is the cerebroplacental ratio. This is the ratio between the middle cerebral artery and the umbilical artery pulsatility. So cerebral PI by umbilical PI, if it is less than 1, it is abnormal. Why? Because normal pregnancy mein cerebral PI is high and the umbilical PI is low. So if the ratio is reversed, it is abnormal. Now friends, let's study the changes which occur in ductus venosus Doppler. What happens in severe hypoxemia? There is a redistribution in the umbilical venous blood towards the ductus venosus at the expense of hepatic blood flow. Consequently, the proportion of the umbilical venous blood which is contributing to the fetal cardiac output is increased. Under unfavorable conditions like hypoxemia, the ductus venosus seems to ensure that the blood flow directly to the fetal heart, and in extreme conditions, the umbilical blood may pass exclusively through the ductus venosus. This may lead to an impaired perfusion of the liver with potential impact on its metabolic properties. On the other hand, you can see that the increased placental resistance and peripheral vasoconstriction which occurs in FGR and is seen in fetal arterial redistribution, it causes an increase in the right ventricular afterload and thus ventricular end diastolic pressure increases. Now this leads to highly pulsatile venous blood flow waveforms and umbilical venous pulsations. Why? Because the arterial pressure gets transmitted through the ductus venosus. So flow waveforms show an increase in the peak systolic forward flow because of increased flow through the ductus venosus, whereas during atrial contraction, retrograde flow occurs because of increased placental resistance and peripheral vasoconstriction. So an absent or reversed A wave is a very late finding which generally occurs about 2 weeks after changes in the umbilical artery. Now to summarize FGR, the first pathological finding is increased impedance to flow in the umbilical artery. Then after that there is an arterial redistribution in the fetal circulation which leads to pathological fetal heart rate patterns. But there is a time interval between the onset of abnormal umbilical artery Doppler and the onset of late fetal heart rate deceleration, which is approximately about 2 weeks. But it can be shorter in late pregnancy and in the presence of hypertensive disease. Next, increased impedance leads to arterial redistribution which causes changes in the middle cerebral artery which leads to decreased PI in the middle cerebral artery. Later on, there are fetal heart rate decelerations which are approximately 2 weeks later after there is a nadir in the brain sparring effect in the middle cerebral artery. And lastly, there is an abrupt increase in the pulsatility of the ductus venosus waveforms. Now friends, let me tell you a very important thing, that the staging of the FGR is also based on the Doppler findings. As you can see, stage 1 IUGR in which there is a mild placental insufficiency and any one of the criteria, if it gets fulfilled, then it is stage 1 IUGR. The criteria is if the effective fetal birth weight is less than 3rd percentile, the cerebroplacental ratio is less than 5th percentile, the uterine artery PI is more than 95th percentile, umbilical artery PI and MCA PI are more than 95th percentile, and the MCA PI is less than 5th percentile. In all these cases, the monitoring is done weekly and termination of pregnancy can be done at 37 weeks with labor induction. In grade 2 IUGR, that is severe placental insufficiency, the umbilical artery end diastolic volume is absent and bi-weekly monitoring has to be done, and pregnancy should be terminated by a caesarean section at 34 weeks. In grade 3 IUGR, there is reversal in the umbilical artery in which termination should be done at 30 weeks by a caesarean section. And in grade 4 IUGR, which is a high suspicion fetal acidosis, there is a reversal of flow in the ductus venosus and there are fetal heart rate decelerations in which the pregnancy needs to be terminated at 26 weeks by a caesarean section. Now friends, let us study one more condition, that is fetal anemia. Now, red cell alloimmunization has been the most common cause of fetal anemia. Fetal anemia is associated with a hyperdynamic circulation. The findings of increased blood velocity in the fetal arteries, which are compatible with the data from the fetal cardiac Doppler studies. The increased velocity would reflect an increase in both central and peripheral blood flow due to increased cardiac output. So the conclusion is that an MCA PSV, as you can see in this picture, the MCA PSV is increased by more than 1.5 multiples of the median, and it may represent the optimal time to perform the chordocentesis and intrauterine transfusion. The recommendation is that MCA PSV should be used as the primary technique to detect fetal anemia. Now, the other important condition is twin pregnancy. Now, how is Doppler applied in twin pregnancy? The first condition in which Doppler is used is twin-to-twin transfusion syndrome. In monochorionic twin pregnancies, there are placental vascular anastomosis which allow communication of the two fetoplacental circulations. In about 25% of the pregnancies, there is an imbalance in the net flow of blood across the placental vascular arteriovenous communications from one fetus, that is the donor, to the other that is the recipient, which results in twin-to-twin transfusion syndrome. In about half of these cases, there is severe twin-to-twin transfusion syndrome, which presents as acute polyhydramnios in the second trimester. The pathognomic features of severe TTTS syndrome by ultrasonographic examination are the presence of a large bladder in the polyuric recipient fetus, in the polyhydramniotic sac, and the absent bladder in the anuric donor that is found to be stuck and immobile at the edge of the placenta or the uterine wall, where it is held fixed by the collapsed membranes of the anhydroamniotic sac. Now friends, in TTTS there is QUINTERO staging to determine the result of the outcome of the fetus. Now, QUINTERO staging for us in case of Doppler, stage 3 is very important because stage 3 is described by the Doppler findings. The abnormal Doppler findings which are found in stage 3 are absent or reversed end diastolic flow in the umbilical artery, second the pulsatile umbilical venous flow, or the reverse ductus venosus flow. Friends, as you can see in this picture that there are pulsations in the umbilical vein with reversal of flow at the end of the diastole in the recipient fetus of a pregnancy with twin-to-twin transfusion syndrome. And in the second picture you can see an abnormal waveform, the ductus venosus, with a reversal of flow during atrial contractions in the recipient fetus of a pregnancy with twin-to-twin transfusion syndrome. If we diagnose this early, that is between 16 and 26 weeks, it allows us the prompt treatment with the laser endoscopic coagulation of the placental anastomosis. Second syndrome in monochorionic pregnancies, which is identified by Doppler, is the TAPS, that is twin anemia polycythemia sequence. Now this TAPS, it can occur after the laser therapy for TTTS, which develops within days or weeks when one or a few tiny AV anastomoses are still present. Spontaneous TAPS can also occur, which most often occurs after 26 weeks of gestation. Now, we can diagnose this prenatally by discordant ultrasonographic abnormalities which show an increase in the MCA-PSV more than 1.5 multiples of the median. Why? Because of anemia in the donor twin and less than 0.8 or 1 in the recipient twin because of polycythemia. Third is the trap sequence or the twin reversed arterial perfusion. In this, there is an arterio-arterial anastomosis directly from one of the umbilical arteries of the so-called pump twin to the often single umbilical artery of the other abnormal twin with pulsatile blood flow to the latter twin. This reversed arterial blood flow is also present in the fetal aorta, which leads to early disruption of the fetal heart development, and consequently there is a formation of the acardiac twin. Now, how can this finding be confirmed? We see by the pulsed Doppler of the umbilical artery of the recipient twin. What can we see in the umbilical artery? There is a reversal of the flow on the spectral waveform. See friends, as you can see in this picture, that this is the acardiac twin, this is the umbilical artery of the acardiac twin, and there is a reversal of flow in the umbilical artery. Now, fourth condition in twins which is used to monitor is Doppler is used to monitor is selective IUGR. Now, what is selective IUGR? Selective IUGR affects 10% of the monochorionic twin pregnancies. What is the main reason for the development of this complication? It is the disparity in the placental territory. How is it diagnosed? When the estimated fetal weight is less than the 10th percentile in one fetus, or the abdominal circumference discrepancy is more than 10 percentile, and second, the birth weight discordance is more than 25%. Now, on the basis of Doppler study, there is classification of S-IUGR based upon the umbilical artery Doppler flow in the growth retarded twin. So type 1, when there is a positive end diastolic flow, we can say type 1 S-IUGR. In type 2, there is absent or reversed end diastolic flow constantly observed during all the examinations. And in type 3, there is intermittent absent or reversed, which is defined as the observation of periods of absent or reversed alternating with periods of positive diastolic flow. So the prognosis in type 2 and type 3 is poor as compared to that in type 1 IUGR. Now, the last but not the least application of Doppler is in screening for aneuploidy. In the screening for aneuploidy, ductus venosus Doppler and tricuspid regurgitation seen are measured. Now, reversed A wave, which we saw in the ductus venosus Doppler, is observed in 3.2% of the euploid fetuses, but it is present in 66.4% of fetuses with trisomy 21. So, if we include the DV flow in the first trimester screening of aneuploidy, it increases the detection rate of trisomy 21. Similarly, tricuspid regurgitation is observed in 55.7% of fetuses with trisomy 21 and in about 1/3 of fetuses with trisomy 18, 13 or Turner syndrome. Similar to reversed A wave in ductus venosus, tricuspid regurgitation measurement also increases the detection rate of trisomy 21 from 91% to 96%. Thank you friends. If you like my video, please click on the like button and subscribe my channel for further educational videos on obstetrics and gynecology. Thank you.